Mr. Anderson will come and offer a few
And
thoughts.
I'm just gonna,
Thanks.
I'm gonna highlight this, Mr. Chair, thank you. What brings us here really is addiction is an illness, is social isolation, right? And this is, we really didn't get into the weeds about why we're doing what we're doing, right? And so what has happened with the social isolation, it's dramatically worsened due to the pandemic. And what we've seen is co-occurring disorders affect each other and every other in different manners. And if there's an untreated mental health issue, Mr. Chair, substance use gets worse. Figure that. If drug or alcohol use increases, mental health issues increase, right? So there's this thing, one and the other. The vicious cycle contains and continues, Mr. Chair, until all the areas of those illnesses are addressed. All the areas of the illness addressed. Then I'm going to talk about a couple of states in particular, but I just want to give you another overview about what you're doing within your bill. When we looked at what is the guts of this really doing. And so the AMA reports that in the U.S., right, individuals with co-occurring conditions, this is real stuff. 50% severe mental health disorders are affected by substance use, period. 50%. 39% alcohol users with at least one serious mental health disorder. 53% drug users with at least one serious mental health disorder. Are you seeing the theme here, Mr. Chair? 29% alcohol or drug abuse among all people diagnosed with a mental health disorder, right? And in Minnesota, then, we tie in, and I think it's important that you look at the overdose deaths in Minnesota. Metro area increased 40% from 2019 to 2020. Statewide, there was an increase of 27% since 2019. Here's a couple that are pretty alarming. 57% increase of overdose deaths in the 25 to 34-year-old piece. 59% increase in opioid overdose deaths 2019 to 2020, and that number is climbing. So everything in isolation, right? This is the theme of what you want to do, what you want to bring forward. 81% increase in deaths involving synthetic opioids. Things don't look well. And so what you're trying to do is simply three things, and I'm going to highlight that, and then I'm going to go into the discussion of the states. Behavioral health audience with the governor needs to be one-to-one, right? Right now it's a division. There's 6 layers beneath the commissioner. And as highlighted when the commissioner presented her slides to you and to this committee last week, I noticed one thing. Number one, the director position, there isn't anybody sitting in there now. Paul Fleischner, who was going to be, he was the wonky guy from Olmsted County. You met him the first time he came to this committee and you went, wow, this guy gets the big picture, right? 1 year. 1 year he was in there. Our understanding on the committee was 3 years, right? And so 1 year. And so what we see there is you elevate this position. Number one, you have a behavioral health audience with the governor. Right now it's embedded, like I said, within layers and with 12 other priorities. And very rarely does it have an audience. And I'm going to give you a prime example of that piece. Even NAMI, in a letter, said many years they've had with many governors, they brought many priorities forward, but nothing came across the finish line, right? Nothing came across the finish line. And so what happens, rather than work coming its way up through a division, it has to get through all these layers to get to a commissioner, and then, oh, by the way, it goes over here, right? In a $21 billion industry, what you're saying is, we got an epidemic. The CDC, NIH, the federal government has said, this epidemic is occurring in the state, in the states across the United States. So what you're advocating is just taking the division and giving it a priority, elevating that priority, which gets to point number 2, Mr. Chair, is what you're really doing is you're placing that individual at a cabinet member to speak specifically to mental health and substance use, and allows this priority to have a seat, and then that person then can issue their own independent budget. Hence, when we talk to other states that have that person sitting at the cabinet level, they get to fight for their own budget. They get to sit there. In the case of Minnesota, you would fight with MMB and the governor and say, no, I want this much, I want that much, right? Now it's happening at a cabinet level, which makes sense because that's what's in charge of all the agencies, right? Not us, the governor is. So in this case, the department allows them to make their case to MMB and the governor specifically. Your bill, Mr. Chair, utilizes the infrastructure already existing as DHS. And I'm going to get this point very clear. As such, the Medicaid issue that people are throwing on the table at you is not a factor. And part of that is because the Medicaid money flows to the state from the feds given authority to the Commissioner of Human Services. And by the way, the Department of Human Services has 42 interagency agreements with other agencies within the state of Minnesota, and one of which I highlighted to you was under the Department of Health, right? The home visiting stuff, it's Medicaid, that's all in there. You're not moving the Medicaid person in there. What you're doing is you're just rearranging the deck to get that priority to the very top of the list. And so, and this more is not directed toward you, Mr. Chair, but so people understand what you were trying to accomplish within this. And the third thing, let me just go back on one thing here. The department utilizes existing infrastructure of HR and legal services, right? It does that now. That's been done under the Minnesota Board of Aging and MNsure. They have autonomy, but they're utilizing the infrastructure of the Department of Human Services. It's a piece of cake, right? Somebody did it someplace else. We did it already. Why can't you do it here, Mr. Chair? As we're saying, third thing, the bill elevates and gives the importance of presence. It's a chronic disease and health care. And I'm gonna talk about, there's a handout you all got from New York Times on the opioid epidemic, right? And in there is one of the folks they talked to was in the opioid report, it was a Stanford report. And the Stanford report has been in existence for 25 years. You ever heard of Stanford University? No? Didn't Denny Green, wasn't our old football, Vikings football coach? Forget it. I'm trying to make the connection, Mr. Chair. 25 years, and they specifically said, and let me just highlight this, what the Stanford report said to you. They came up 7 different recommendations. Recommendation 3A, right? They made a comment. Integrated evidence-based and enduring systems for care of substance use disorders should be built and supported financially, right? And what their recommendation is saying, based on the opioid epidemic, right, and based on the mental health and substance use, is that health and social care systems must make an enduring commitment to provide services to people, right, with substance use disorders. This must be fully integrated with mainstream healthcare systems, right, and be equally accessible. And what they're meaning by mainstream, ready for this? They're talking about hub and spokes, Mr. Chair. Primary care, mental health care settings, outpatient addiction treatment, and clinics specializing in chronic pain management. They're all saying that has to be an integrated approach to it. Right now, it's all siloed, as evident, because we've had the same statistics come out with the same thing for years and years, and yet at the same time, this opioid epidemic and the fact that our substance use and mental health epidemics are going through the roof, right? It's time to really look at integration. Your 3 things that you talked, that I just highlighted for you is there. And the 7 things that this bill simply breaks down, I highlighted in those 3, and it creates a Department of Behavioral Health, right? And it gives that commissioner the authority to appoint department heads, right? That's the second thing. The third thing, we establish salary limits that are already embedded in the law. Nothing's changing within law. You also allow a commissioner to do unclassified positions, as any other commissioner gets to do. And then once created, the governor appoints the commissioner, and there are 4 points established under 245T.01, right? And that's really to look at how that integration is going to occur within the infrastructure that already exists. It's not talking about anything other than that, right? And then you get down to the section that really talks about transferring of duties, right? And what that transfer of duties, and it finally, Mr. Chair, the language in the legislation is really an elevation of this epidemic at the cabinet level, period. That's it. It's not the sky's not falling, the world's not falling. This is really good language, what you put together, and it caused me to do my research like you had asked me to do. And finally, what it really does is you tell then in the transfer of duties, embedded within the construct of that umbrella, you finally then say you instruct the reviser to consult, and you listed who those necessary agencies and necessary people were in order to prepare legislation for the 2023 session that says, how is this thing lining up? So you've created this doorway to be able to say, we want to look at this by taking this division and going up here with it. It's brilliant stuff. So you ask the same question, you say, all right, well, what about other states? Well, as of February of 2022, there are 13 states that have behavioral or mental health departments. 13 states, mental health departments, not divisions, and that are either on their free-standing or separate entities, right? And quickly, I'll list Alabama, Connecticut, Georgia, Massachusetts, Mississippi, Missouri, New York, Ohio, Oklahoma, Rhode Island, South Carolina, Tennessee, and Virginia. It's kind of like that song, you know, remember that song? Thank you, Toby's. See, they remember that song. I would have done it. Anyway, the thing that really comes into play here is that the survey that I found when I looked at all these states, right, is that there are 16 key administrative functions from eligibility policy to fraud and abuse, right? 16 key administrative functions. This is important because everybody says, not everybody, but people, the naysayers to your bill, which is a brilliant bill, by the way. I got to tell you that. And so it's supposed to be funny, but it's not. There are 16 functions in Medicaid, right? And so there are only, 5 states, Colorado, Illinois, Massachusetts, Minnesota, and Nebraska, that does the full spectrum administration of all 16 functions, right? 29 of the states in the United States contract one or more of the 16 functions to a private sector. Now, I'm not for privatization, but I will tell you this, the most contracted piece of all those 16 functions is the Medicaid Management Information System, the MMIS system. Isn't that, you find that kind of odd? So you wonder why we're looking at a $21 billion department and saying, are all the priorities of this somewhat small part of the department, DHS, not getting elevated to the top? Again, I'm going to highlight that PowerPoint that was presented last week showed exactly why there's a missing document in there. It needs to be extracted out. So the 3 things that I highlighted for you, Mr. Chair, are exactly what's important. So when we look at a couple of states, I'll give you one example, and then I want to get Mr. Anderson to kind of talk about his perspective on this. But even within our own state, Mr. Chair, you had a presentation or a letter from the association that does the Excellence in Addiction Care, Association of Addiction Care, inpatient, outpatient folks. And they even said the intent of what you did is to lift up and address the growing crisis of disease and addiction in Minnesota through development and implementation of an inclusive, comprehensive response during this critical time. It's lined up. On the federal level, they're saying we're in an epidemic, right? Stanford's saying it's got to be integrated, right? 25 years, I guess Stanford doing what the New York Times saw it. I got the New York Times, but the fact is that's where the Stanford folks were when they were talking about this 25-year capacity, and they're looking at it saying this is what needs to happen. It's got to be integrated, and you've got to include primary care, mental health, substance use. It's got to be. Right now, that's not what's happening in Minnesota, right? From what I've seen in the presentations, Mr. Chair, and what you're talking about, the concern that sits out there, that's exactly what's happening. And so the other thing that the inpatient outpatient providers said to you was, we support reform that ensures Minnesota has a singular, elevated, and coordinated approach. Comprehensive, coordinated. My 3C started coming into my Public Law 99-457 discussion, which we've had for 20-some years. But the elevated and coordinated approach across substance use continuum of care. Now we're talking Senator Murphy's continuum of care, nursing services. That's right, the whole thing about continuum of care. Where is this whole perspective on the public health side of this? And it absolutely hits in there. And this approach, Mr. Chair, must include education, prevention, treatment, support services, and recovery. It's a continuum of care. It's a non-siloed approach. It's bringing all those things collaboratively. I love what they said in that letter. And then what I really like is it is beyond time. And Senator Eaton said this when she first presented the bill that you two are on. It's beyond time. Minnesota has a plan that utilizes a full continuum of care that can be managed and implemented. Okay. Well, other states aren't like Minnesota, and they're saying, oh, it's tougher. We want to be more like Minnesota. Well, when you looked at those 13 states, I'm going to one for example. Is some of the stuff in New York City, people were talking about wanting to integrate or not integrate, and they have one portion of it, but they really wanted to do the umbrella. And they were getting the same pushback from the bureaucrats and from those that are operating in silos regarding, and here's what I've seen. What they've seen in the departments, there are silos that are priorities that do not get raised to the surface, right? And so the protocols in the state of New York ended up being fragmented, right? And so, I mean, there's more to that, but those are the kinds of conversations we're getting from states. Those that are doing it well are doing it well. Those are struggling with the fact that there's still a bunch of folks that are saying, oh no, we like what we're doing, you know? And if I haven't convinced you that your bill makes sense when it comes to those three things it's doing, it's just elevating the priority. And this is what the governor, he absolutely talks about addiction and mental health. He's always talking about it. This gives him authority to be able to now place that as a priority in the state of Minnesota. I think it's wonderful that we're having this conversation. I'm glad I could be part of helping you understand what the lay of the land is, Mr. Chair. Is that okay? And with that, I think Randy Anderson is here to chat with you as well.